Morning to all of you. I warmly welcome everyone on this Sunday morning for today's CPD program, co-organized by Government Medical Officers Association and Society for Health Research and Innovation. Our webinar link will be available to you from 9 to 9:50 a.m. and no late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the e-certificate for participation. The CPD points will be given to you, which are strictly adhered to NCCPD guidelines, but the e-certificate will be given regardless of the CPD points. The link for applying e-certificate will be closed few minutes after the end of the session, and also the chat box will be open to you for your queries, and the answers will be discussed at the end of the webinar. Also, we kindly ask you from all of you to mute your microphone and the switch off your video to avoid any interruption during the webinar. Now, let me introduce today's speaker, Dr. Sanath Rajakaruna, Consultant Emergency Physician at Teaching Hospital Ratnapura, to present today's webinar on emergency management in poisoning toxicology, do's and don'ts. This is over to you, sir.
Thank you very much for the kind introduction. And I would like to thank Government Medical Officers Association and Society of Health Research and Innovation for inviting for this lecture, which is a very good initiative to improve knowledge of our doctors. And it's 26th of December, the day of tsunami, one of the saddest days in Sri Lankan history, and the date which highlighted the importance and the requirement of emergency care services in our country. And it's a coincidence that an emergency physician doing a lecture on one of the most important topics, one of the important causes of preventable deaths in Sri Lanka. And I'm going to do this lecture on emergency management in poisoning, toxicology, do's and don'ts. Why it is important? Suicide is the 11th major cause of death in our country, and poisoning is one of the main causes out of that. And also the drug use also in the one in top 50 causes for cause of deaths. And considering, even though it's 11th, the suicide is 11th in the list, considering the years of age, years are lost, and the activity disability adjusted life years lost, it is one of the third highest causes considered as suicide. And as I said, poisoning is one of the major causes, the ways the people get suicide. And the other important reason is considering the mortality. Sri Lanka has about 10 times higher mortality than developed countries when it comes to management of poison patients. Probably it's something to do with the type of the poison used, but there may be room for us to improve as well. Right? And these are the two major hospitals I worked. And first I worked in Teaching Hospital Kurunagala, A&E department, and now I am working at Teaching Hospital Ratnapura. We will, over next 45 minutes to 1 hour, we will discuss about few patients which I got and I have managed over the last few years, and we will discuss approach for managing all those patients. These are the patients I got to BC Emergency Department. The first patient I got was 24-year-old female with medication poisoning, and she was in cardiac arrest on admission. The second one I got 60-year-old male brought after ingestion of brake fluid, and his systolic blood pressure was 60, and his GCS was 3, and he was really unstable. And third patient, 67-year-old male with history of depression, brought in with generalized tonic-clonic convulsions lasting more than 30 minutes. Fourth one, 25-year-old male, a rehabilitated drug addict, brought with reduced responsiveness. And his blood pressure was, systolic blood pressure was around 90, and he was bradypneic with GCS of 12. Fifth, 18-year-old female, presented after deliberate ingestion of 24 tablets of paracetamol 45 minutes back, probably one of typical straightforward presentations. She was perfectly stable on presentation. And we will discuss a generalized approach for managing all those patients, because we can't have different approach for all those poison patients, and it will be really difficult for us to manage in a busy emergency setting in that case. This is the approach I'm going to discuss. RISAS RSI 10. This is a mnemonic developed, and RISAS stand for the initial resuscitation, if patient needs resuscitation. Then RSI, R stand for risk assessment, S for supportive care and monitoring, I for investigations, D for decontamination, E for enhanced elimination, A for antidotes, and D for disposition. We will discuss one by one, and then at the end, we will apply this principle for management of the above mentioned patients. Right. Resuscitation. It is the basic concept. Yes, it is not just like A, B, C, D, but initial, if patient is not maintaining airway, you have to stabilize the airway, like probably sometimes basic manuals may be adequate, sometimes you may have to go for advanced airway like intubation. And then breathing, check saturations, check respiratory rate, and assess breathing, and if necessary, do necessary managements like probably give oxygen, probably you need other advanced measures. Then management of circulation, check capillary refill, check heart rate, check blood pressure. If anything abnormal, correct it. And if patient is running arrhythmias, probably then take necessary measures to correct those arrhythmias. Then seizure control also comes under resuscitation. It is quite different, like seizure control is little different in the poison setting. Like we use benzos like midazolam, lorazepam, or diazepam we can use, and we can use repeated doses as well. But the second line usually is a barbiturate, not the phenytoin, because many of the poisons cause QT prolongation, and phenytoin can also worsen the issue. Therefore, it can worsen patient's situation. Therefore, we go for benzos and then for barbiturates, like phenobarbital. And then correct hypoglycemia. Make it a habit. When you get a sick patient, always check for capillary blood sugar, because that may be the reason for reduced level of consciousness. Yes, we can check level of GCS, but it is not a validated tool for poison setting. GCS or AVPU scale is for trauma patients. The aspiration, like there are evidence that significant aspirations do happen even at very high, like even GCS from like 12 to 14 as well in poison patients. Therefore, the GCS less than 15 is a risk factor. The patient have high risk of aspiration in poison setting. Then check for temperature. If patient hyperthermic, take measures to control it. And if hypothermic, may need warm fluid, warm saline, and other measures to improve the core temperature. Then we we can use certain antidotes in the resuscitation, during resuscitation itself, like naloxone in opioid poisoning, sodium bicarb in tricyclic antidepressant like Tca poisoning or poisoning of like toxic alcohols. We can use high dose insulin, euglycemic therapy, intralipid for local anesthetic toxicity, atropine for organophosphates. Those things we can utilize during resuscitation itself. The resuscitation takes the priority over anything else in the poison, like management of poison patient. Then once we do resuscitation, then we do risk assessment. How we risk assess? We check agents, what the patient have taken. Like patient may have taken just 24 tablets of paracetamol, or patient may have taken like many types of medications and many doses. And we have to know the agents and the dose to decide whether this is at a toxic dose or not. And at what time the patient has taken those, because it decides the method of management, like how long we're going to monitor. Those everything will be decided on the time of ingestion. And the current clinical status, whether the patient is stable or unstable, whether the patient is developing features of toxicity. And then the patient factors like age, body weight, other medical comorbidities, other medications patient being on. Those are very important during the management, because all those will be added problems for us during the initial management. When we approach a poison patient, we can take get some details from history, from the patient or from the relations. But as emergency doctors, sometimes we do not have that luxury in getting a detailed, proper history, because patient may be very sick on presentation, and sometimes patient may be reluctant to give information because patient really wanted to die. And then we may have to go for other clinical features or clinical parameters to decide what the patient have taken and how much patient may have taken. And we stick to it. Please think about it. Physical examination is very important, not only the investigations and the history. Like we can check blood pressure, heart rate, like blood pressure may be low or high, heart rate may be regular, irregular, tachycardic, bradycardic, depends on the poison patient may have taken. Pupils may be normal, dilated, or small pinpoint pupils. Lungs, maybe a lot of crackles, maybe patient may be bradypneic or tachypneic. And his skin, maybe patient may be really sweaty, or patient may be really dry. And temperature, patient may be hypothermic or hyperthermic. Those collection of symptoms lead us to the poison, possible poison patient may have taken, if we do not have the luxury of getting a detailed history, or patient do not give proper history. And when we assess those symptoms, a thing called toxidrome, we can put the symptoms and signs together, which direct to a particular toxin or particular collection of symptoms. There are like common toxidromes like anticholinergic toxidrome, which cause like dilated pupils, patient will be having high temperature, patient would be really warm, tachycardic, and that is anticholinergic toxidrome, like situations like in atropine poisoning. And the other thing, like patient may be having diaphoresis, vomiting, urine and bowel incontinence, and patient may be sweaty, bradycardic, that is cholinergic toxidrome. Things like organophosphates. And sympathomimetic toxidrome, which cause tachycardia, dilated pupils, and patient would be sometimes agitated and having tremors. Those things can happen, like in situations like sympathomimetic, like psychostimulant, or like antihistamines sometimes cause things like that. And then opioid toxidrome, like patient would be having reduced respiratory rate, patient would be really drowsy, and urine incontinence or like with the urine retention can be there. Those things will be direct us to a different toxidrome, like opioid toxidrome. These are the like collection of that's why it is important for us to clinically examine to identify what is the possible poison the patient being exposed to. Then we can start management as per the clinical features. Like this is a diagrammatic representation, like what different features we can see, like anticholinergic toxidrome. There will be dilated pupils, increased heart rate and blood pressure, patient will be like and dry patient. And like opioid toxidrome, like in heroin, the patient would be bradypneic and bradycardic, hypotensive, and like having pinpoint pupils, and patient would be dry. And cholinergic toxidrome, pinpoint pupils still, but the patient would be really wet or sweaty and increased secretions. Those are the like different features we can use to differentiate different toxins. Then the S is for supportive care, which is a very important part of managing poison patient. I would say it is the most important part probably. Like there's a mnemonic called fast hugs in bed, please. This mnemonic is derived from actually intensive care. It initially started with fast hugs, and then it had evolutions over the years. If for fluid therapy, we have to concentrate on IV fluids or oral fluids and feeding, and like give proper analgesics, proper sedatives, thromboprophylaxis, ulcer prophylaxis, head up positions if intubated. We have to control the blood sugar, skin and eye care. We may have to catheterize and monitor urine output, have to insert nasogastric tubes, proper bowel care, have to control the environment, and de-escalations in situations of like, if depends on the progression or the end of life situations, and the psychological support for the patient and the family. And then I stand for investigations. The important investigations, there are 3 Gs. In emergency department, we rely a lot on these 3 Gs. First G is glucose. It is very important. As I said, the reduced level of consciousness may be because of the glucose or reduced sugar. Then second G is blood gas, which is very important because you may know that many of the poisons can result in acidosis, like metabolic acidosis, high anion gap or normal anion gap, certain cause respiratory alkalosis and respiratory acidosis. It is very important investigation, especially in situations in poisoning. And the ECG, also a very important investigation in poison patient, because there are many poisons which resulted in ECG abnormalities, like sodium channel blockers, like Tca poisoning, local anesthetic poisoning, and like carbamazepine, propranolol. All those can result in Qrs prolongation. And potassium channel blockers can result in QT prolongation, like macrolides, antihistamines, and so on, and antipsychotics, those medications. And things like digoxin, sodium potassium ATP is pump inhibitors, can result in heart blocks and different types of arrhythmias. And certain medication, certain toxins can result in hypocalcemia, which result in QT prolongation. Certain can cause hypokalemia and hyperkalemia. All those things we will be able to assess by doing ECG. Therefore, make it a habit to do a ECG for all like undifferentiated or like identified poisoned patients. And we can do other investigations as well, not for all, but as required. We can do like renal function, liver functions if necessary. And yes, we can send for toxicology screening if necessary. And we can do basic investigations like counts, coagulations to get baseline if needed. And we can do radiological investigations for certain patients, like in situations of suspected aspiration, or we can do chest X-ray if reduced level of consciousness to check for sinister causes. We can do a CT brain, and that is not for all. And urine toxicology screening, actually it is of minimum or no use in acute setting. Actually, it is more than the clinical use. It's more of a medical legal requirement in some of the settings of like deliberately poisoned patients or situations like that. But because the toxicology screening, urine toxicology screening, it takes time for us to get the result. Like sometimes it takes delay more than a day, and it is not freely available. And it may be useful for the like consultant or the doctor in the ICU or the physician, but in the ward. But from our point of view, it's of very minimal use. And make sure you rationalize your investigations when you do investigations in acutely poisoned patients. Like it is being used for like to take decision on prognosis or severity, or the like to identify different poisoning and to decide on the type of treatment we're going to use, and sometimes to check the basic function, basic parameters or the basic the baseline, and to identify whether it is getting deteriorated with the time. And those are the indications, like those are the reasons why we do investigations for those patients. And next, we have discussed RSAS and RSI, then D for decontamination. GI decontamination is a common method of practice, and we will discuss one by one. And we can do like skin and ocular decontaminations in situations of external exposures. That the method of decontamination, like, and the use of decontamination being decided on the severity of poison and the like at what time the patient has ingested that particular poison, and the risk of considering the risk of intervention as well. Considering decontamination methods, I know induced vomiting was practiced in the past, but it is still being practiced in some of the hospitals in our country. But it is not a safe method of decontamination. It is never been done in developed setting. It is not advisable to do induced vomiting even at home as first aid measure, because vomiting does not fully empty the stomach, even if patient can safely vomit. And vomiting can cause person to delay getting appropriate treatment, and either vomiting can result in aspirations, and it is not a good method of decontamination. If you're gonna take one message from this lecture, just take this message: never do induced vomiting for a poison patient, which cause a lot of problems. And I have managed a lot of problems which has resulted due to induced vomiting as well. Never do this. Induced vomiting is not equal to gastric lavage. It is not. Never do it again. Then the second thing, gastric lavage. Yes, we can use gastric lavage for certain patients, but the thing is, like, amount of toxins removed by gastric lavage is quite unreliable, and it is often negligible when it is done after 1 hour. But we can use gastric lavage if patient presented very early after the ingestion, and if the patient have taken a medication which can stay in the stomach for a longer duration, like causing like sometimes aspirin can stay for longer time, and there are medications which cause like delayed gastric emptying. And if we do not have a specific antidote for that particular drug or particular poison, yes, it's no harm, like we can give a try and do gastric lavage. But make sure you do initial resuscitation first. Risk assess and like check a good outcome with supportive care. And risk assess and decide whether the good supportive care and antidote may be enough. Like it may not need to go for gastric lavage. And make sure you protect your airway, the patient's airway. And if patient is having decreased level of consciousness, better not to do it unless the patient being intubated. Don't do it in very small children. And corrosive injections, hydrocarbon, don't do it. And how we do it? We insert a orogastric tube or like a large bore nasogastric tube for patient, and we put about 200 ml of water or normal saline aliquots, and then the gravity to drain it, and we have to keep the patient head down position, lying down in about 20 degrees head down, and that is how we exactly do it. It can cause complications, but you can do it, but it has a limited practice only if the patient presented within the first hour, or in extreme situations you can go even after that. But and if we do not have a proper antidote or like supportive, if the patient, the supportive care may not be adequate, then we can go for it. Then activated charcoal. Usually it has place if the patient has ingested the poison within 1 hour. Long and repeated doses can be given in situations like aspirin poisoning, and like in sustained release preparations, we can give even for a longer duration. The usual dose is like 1 gram per kilogram or 50 gram in adults in 100 ml. Still, you make sure the patient is fully conscious to give activated charcoal. If patient is having intractable vomiting, repeated vomiting, don't give it, because if patient get aspiration of charcoal pneumonitis is a pretty bad situation. It can result in more problems than the problems resulted in because of the poison. And it can sometimes cause constipation like and bowel obstructions even. And it is not the medication for everything. Charcoal doesn't absorb several things like caustics or corrosives. No point in giving it. For heavy metals like lead, no point in giving it. Toxic alcohols, no, it's not getting absorbed. If the things getting absorbed very rapidly like cyanide, no point in giving charcoal. And chlorines and iron, lithium, hydrocarbons, don't give it. Don't give charcoal for patients who got poisoned because of these poisons. It will complicate the issue. It will not be helpful. Another quite unpopular method of decontamination is whole bowel irrigation. We can use polyethylene glycol, what we use for bowel preparation for colonoscopy. It decrease absorption by reducing transit time. It is suitable for conscious patients who have ingested that medications which do not bind well with charcoal. And we may have to give this whole bowel irrigation for about 6 hours. We have to allocate a staff member for about like 4 to 6 hours for that patient. And indications are like life-threatening, like injections of sustained release preparations, we can use. The questionable use in illicit drug packets, and like iron supplements, lead, foreign bodies, lithiums, yes, we can use, but it is contraindicated in unstable patients. If patient is having intractable vomiting, don't give it. And if drug packs are leaking, if suspected leaking, don't think about going for whole bowel irrigation. Then E for enhanced elimination. Enhanced elimination also can be practiced in certain situations. There are several methods we can use for enhanced elimination. One thing is multiple dose activated charcoal. We can use for carbamazepine and theophylline. Initial dose is like 50 gram as usual, and then we can use repeated doses every 2 hours. And then a urine alkalization also have a place, like in situations like salicylate poisoning, like aspirin or methyl salicylate. But make sure during alkalization, check for potassium. If potassium is abnormal or less, correct potassium before you give sodium bicarbonate, otherwise you are in trouble. And then we can use hemodialysis to remove medications or the poisons as well. That is also a method of enhanced elimination, which we can use for like situations of toxic alcohols or severe salicylate poisoning and so on. Then we have antidotes. There are specific medications we can use to reverse the adverse effects of the poisons. You can't remember everything. That's why there are books you can refer, like any poison book, or like you can refer websites like Medscape or internet somewhere, or you can contact the toxins information center. And but there are important things like you may have to remember, like for amphetamines or psychostimulants, benzos, you can use benzodiazepines, like causing respiratory depression, you can use flumazenil. And like opioids, you can use naloxone, organophosphate, atropine, as you know, like in Tca poisoning, sodium bicarb. But important thing are, there are certain medication that we cannot be used in during the poison patient, and we will discuss those during the case discussions. Then D is for disposition, where the patient ended up after initial management in the accident and emergency department. If patient really unstable and need respiratory support, probably patient need to go to ICU. And if patient need like period of close observation, probably HD would be ideal. And some patients can be sent to ward after initial management. And that's how, that is the approach we're going to use to manage a poison patient, resus, RSI, dead. Now, over next 20 to 30 minutes, we will discuss cases which I presented at the start. And we'll apply this principle, and we will discuss few concepts around those specific poisons as well. First case, a 24-year-old female with medication poisoning, cardiac arrest on admission. And we implemented like resus RSI dead approach, and we started immediately resuscitating. We knew the patient was it was a medication poisoning, but we did not know what was the exact poison to start with. An initial rhythm was asystole, and we followed the standard advanced life support algorithm. But within short duration, we got to know the patient has taken amitriptyline overdose. Patient was a drug dispenser in a GP practice, and she has stolen this is the bottle the mother brought. She stolen a bottle of amitriptyline from the GP practice, and she has drank more than 30 tablets of amitriptyline. And how we resuscitated? We gave more than 200, like initially we gave 200 ml of 8.4% bicarbonate during resuscitation to get her back. And I will show the rhythms we got after resuscitating from the cardiac arrest. And the patient finally walked back home in 5 to 6 days. Like in 5 days, she was ready to go, but she had to stay for 6 days for psychiatric review. There were no neurological deficit. This was the first one, and the second ECG, first and the second ECG we took after resuscitating from the cardiac arrest. You may notice obvious QRS widening. QRS is definitely around 200 milliseconds, and can't really see a P wave, probably buried in the T wave. QT is definitely prolonged, and you may notice like dominant R wave in AVR. These are the the same ECG. You may notice like subtle narrowing with time of QRS complex. This is the first and the blood gas we took after period of resuscitation. Initial pH was 6.8 and CO2 of 80 and bicarb was 13, and the second one with pH of 7.3 with CO2 of 40 and bicarb of 21. How we managed? Yes, initially we followed the standard advanced life support algorithm, and during resuscitation we have given 1.5 liters of saline and 200 milliliters of 8.4% bicarbonate, and we intubated the patient, intubated and hyperventilated, and still the patient's blood pressure was in the lower side, and we inserted the central line, started no adrenaline infusion. And even after this, like resuscitation, we had to give, think, another 150 of sodium bicarbonate. It's a very high amount, and we have to replace potassium as well. And for the risk assessment, our patient has taken around 30 tablets of 25 milligram amitriptyline about 1 hour back. And supportive care, we inserted indwelling catheters, gave IV antibiotics for because of the possible aspiration, and we continued close monitoring, and we did the investigation wise 3Gs were done, and the following that we took all the basic investigations. And as per decontamination, after intubation, we inserted a large bore nasogastric tube, and gastric lavage was done, and activated charcoal was also given following the gastric lavage. Enhanced elimination was not practiced for this particular patient as antidote. Further sodium bicarb was given, and patient ended up in intensive care unit at Kurunegala. And considering Tca poisoning, we'll discuss a little bit on Tca poisoning. What is Tca? Tricyclic antidepressants. It's a common medication used in general practice for neuropathic pains and certain psychiatric problems. We use amitriptyline, and the psychiatric patients use things like imipramine. And tricyclic antidepressant, what it causes? It is the noradrenaline and serotonin reuptake inhibitors. It gets rapidly absorbed, and peak level reach within 2 hours. If we consider risk assessment, it will cause only minimal symptoms if less than 5 milligrams per kilogram, 5 to 10 drowsiness and mild anticholinergic symptoms. And any decontamination method is not advised if the patient being taken less than 10 milligrams of kilogram, because it do not cause significant problems for the patient. If patient has taken more than 10 milligrams per kilogram, it can be potential life-threatening, and we have to closely monitor the patient and manage the patient appropriately. Clinical features are the CNS features comes first, like sedation initially, and then coma. Seizures can happen. If seizure occurs, benzosis is the management. Cardiovascular wise, patient will be tachycardic initially because of anticholinergic effects. Hypotensive, and it causes broad compressed tachycardia and develop bradycardia pre-arrest. And anticholinergic symptoms cause mydriasis, dry and warm, and agitation can happen. Right. And regarding investigations, ECG plays a vital role in the management of Tca poisoning. Qrs prolongation happens because of blocking of fast sodium channels. If Qrs duration more than 100 milliseconds, it is predictive of seizures, and if more than 160, it's predictive of ventricular tachycardia. Large terminal R wave in AVR is a feature of sodium channel blockade, which can happen in other situations of sodium channel blockades like carbamazepine. Propranolol can also result in sodium channel blockade, and QT prolongations happens due to potassium channel blocking. All those features can be identified in the ECG itself, and we have to manage those. And we have to closely monitor the patient at least for the first 6 hours. And if patient is having CNS depression, like even less than G12 of GCS, probably patient needs intubation and hyperventilation. When you intubate this kind of a patient, like Tca poison or a toxic alcohol ingestion resulted in poisoning, intubation itself can result in bit of elevation of carbon dioxide levels, and little bit of respiratory acidosis can happen. Therefore, don't take a risk. It is a risky situation in poison patient. Probably use drugs like sodium bicarbonate before intubation to damp that acidotic response. For ventricular arrhythmias, if happens, cardioversion and defibrillation is not effective in this kind of patients. You have to use the drug that is sodium bicarbonate. 100 millimoles is 100 ml of 8.4% bicarbonate. You have to repeat it until rhythm is restored. Keep an eye on potassium. If potassium is low, you may have to replace potassium. And never use amiodarone. Please be really cautious when you use amiodarone for arrhythmias resulted due to poison, because amiodarone causes QT prolongation. There are many poisons which cause QT prolongation. If you give amiodarone for those patients, you are in big trouble. The patient's problem can get worse. Therefore, avoid amiodarone in this kind of patients. If hypotensive, you can use crystalloid bolus, that is normal saline, the crystalloid we use for these kind of patients, and we can use sodium bicarb to increase sodium load, and you can use inotropes like adrenaline or noradrenaline infusions. It is not always necessary to use a central line. You can use peripheral lines to give noradrenaline infusion. It is perfectly safe. For seizures, it's always benzodiazepines is the first line. 3 goals of management: narrowing of QRS complex to normal for the patient, and targets. You can give sodium, like sodium bicarbonate, until the patient's sodium level reach 155. Aim pH of 7.5 to 7.55. That is rather in alcoholic range. You can use bicarbonate until that level. Decontamination not indicated if patient has taken less than 10 milligram per kilogram, and do it only after securing the airway, because patient would be really drowsy after Tca poisoning. Therefore, don't try decontamination in a drowsy patient. You are in trouble. Then we'll move on to the second. This is a 60-year-old male presented after ingestion of brake fluid. On admission, he was hypotensive, tachycardic, and had GCS of 3. This blood gas was after a few minutes of resuscitation, pH of 7.1 with bicarb of 22 as element of respiratory and metabolic acidosis. And this is the exact the brake coil the patient has taken. He has drank a brake coil made in Japan. It's a very hi-fi stuff he has drank. What is the problem with brake coil? It is composed of mixture of toxic glycols or glycol ethers. In mild toxicity, it causes nausea, vomiting, and drowsiness like in alcohol intoxication. In moderate toxicity, called mild metabolic acidosis, hypertension, and bit of tachycardic response. And the severe toxicity is the problem. It causes severe metabolic acidosis and cause seizures, can go into coma, and the patient can develop renal and multi-organ failures. Right. How we managed this patient? The patient was unstable initially, and we gave IV fluid crystalloid resuscitation. 1 liter of normal saline was given. We oxygenated, intubated and hyperventilated, and we gave sodium bicarbonate prior to intubation in this case. And still the patient's blood pressure was low, and we started no adrenaline infusion with peripheral line. That is how we resuscitated the patient. Then risk assessment, patient has taken brake fluid, but time was not clear. The relations were not aware at what time patient was taken those. And in supportive care, we monitored, we put an interlink catheter and urine output was monitored. And 3 investigations like 3Gs, gas, ECG, and the glucose were checked. And the basic investigations, including serum osmolality and UFR, was sent off. Decontamination, we haven't practiced any decontaminations here because in the toxic alcohol setting, it is not effective. Like gastric lavage or charcoal, nothing is effective for decontamination. Enhanced elimination was not practiced in here. And as antidote, we had to get down a bottle of vodka. We got down a bottle of vodka. We went for like very expensive stuff, and relations happily bought a bottle of vodka, and we had privilege of opening bottle of vodka in the middle of the A&E department. And we gave 100 ml via NG tube, and then repeated doses were given every hour, and cofactor replacement was done with IV thiamine 100 milligrams, and patient ended up in ICU, and patient recovered well. And thinking about toxic alcohols, we have 3 main toxic alcohols. One is ethylene glycol, other one is methanol, and other one is the isopropyl alcohol, which we use commonly now. Like if there's significant absorption from our hands, we may get toxic very frequently. Like one ethylene glycol, it is rapidly absorbed when we ingested it. The peak concentration reached within 1 to 2 hours, and it is a colorless, odorless liquid, and which has a sweet taste. Therefore, never keep in the closer distance to a kid, because they may taste it. It contains in coolant mixtures, because it is a coolant are like very colorful chemicals as well, and therefore kids can be very interested on those. It contains in brake oil, antifreeze, those in the kind of stuff. Methanol also a rapidly absorbed chemical, and which is colorless, but it has a distinctive odor. It contains in windshield washing fluid, varnishes, paint removers, like in octane boosters, which we use, and in like illicit alcohol, we may get to know in the news that several people have died because of the illicit alcohol. That is because of methanol. What those poisons cause? Ethylene glycol, it causes neurological symptoms, like it result, then initially it causes sedation, then seizures, comas can happen. Cardiovascularly, like it causes tachycardia, and then it result in like hypocalcemia because of the oxalic acid combines with serum calcium, result in hypocalcemia, result in QT prolongation, and patient can develop ventricular tachycardia. And renal toxicity can result in, because of the calcium oxalate crystals go and precipitate in renal tubules and cause acute renal failure. Methanol, it is mainly retinal toxicity, like it causes blurry vision, reduced visual acuity, classic snowstorm vision can happen. Neurological wise, it causes like basic sedation, like drowsiness, headache, can go into coma, and sometimes it can cause situation like conditions like transverse myelitis as well. Then regarding isopropyl alcohol, which is rubbing alcohol or hand sanitizer gels contain isopropyl alcohol, which get metabolized by alcohol dehydrogenase to acetone without production of like anion gap acidosis. But patient may be really drowsy and patient may have ketosis but without acidosis. It is the basic management is supportive care. We do not give alcohol in this situation because its metabolite acetone is like it do not cause much of harm other than the sedation. It's got clear like excreted from kidneys. And sometimes like proton pump inhibitors or H2 blockers can be useful because some patients can develop hemorrhagic gastritis and patient can die of gastric hemorrhages because of the ulceration. This is what happened. Isopropyl alcohol dehydrogenase convert into acetone, and methanol, the toxic metabolite, is formic acid. In ethylene glycol, the toxic metabolites are glycolic acid, and then it metabolite into oxalic acid. Those are the toxic metabolite which result in problems. Then what we do in the management is we block alcohol dehydrogenase enzyme here. And by blocking alcohol dehydrogenase, we stop formation of these toxic metabolites and we let the methanol or ethylene glycol to be excreted through kidneys. That is our aim. How we achieve that aim? Considering management, lavage or activated charcoal is of no use. Please do not concentrate on that. Please concentrate on resuscitation and airway protection and other managements. We can use cofactors like in ethylene glycol, we can use pyridoxine 50 mg 6 hourly or thiamine 100 mg 6 hourly. That will increase metabolism of like glycolic acid to less toxic metabolites like shown in here. And in methanol poisoning, we can use folic acid or folinic acid to increase breakdown of formic acid. The important thing is the antidote. There are two antidotes we can use in ethylene glycol poisoning. That is, one is fomepizole, another one is ethanol. And sometimes it may not be like if patient has ingested very large amounts, it may not be adequate. And if patient presented several hours after ingestion, and by the time the patient may have developed like all these toxic metabolites, in that situation, the antidote therapy may not be adequately helpful. In that situation, probably you have to go for hemodialysis to remove toxic metabolites. You can use sodium bicarbonate for metabolic acidosis because undissociated forms of this formic acid is like more toxic than the dissociated form. To do that, we can use sodium bicarbonate. And these are the advantages and disadvantages of ethanol versus fomepizole. Ethanol advantages are inexpensive. I really doubt it is inexpensive. It's quite expensive in our setting, but it is freely available, yes, in the oral form. Disadvantages are it is having low affinity for alcohol dehydrogenase. Therefore, we have to give large amounts. It increased serum osmolality. Therefore, it obtained the way of monitoring for us because the alcohol also causes increasing serum osmolality and it impairs mentation. Then the patient may need intubation and go into ICU. And ideally, we have to monitor alcohol level as well, even though we do not do it here. We have to get the proper alcohol level to block that alcohol dehydrogenase. Regarding fomepizole, its advantages, it is having very high affinity for alcohol dehydrogenase enzyme. It is about 500 to 1,000 times more selective or more having more affinity than alcohol, ethanol. It has minimal adverse effects. It do not cause increasing serum osmolality. It do not cause impairment of mentation. Therefore, it is a quite useful drug. Disadvantages are it is not available in all clinical settings. Said to be expensive in and not registered in some countries, but in Sri Lanka, what you have to do is in the annual drug plan, please request it. IV fomepizole 1 milligram per ml, 1.5 ml vial cost about just 25 rupees as per last year annual drug estimate. Just 25 rupees. You can't even buy a plenty for that price. Please use it. Ethanol, how we use it? We can use NG 43%, 1.8 ml per kg loading, then hourly you can give, or IV preparation. I have never used IV preparation here. Had to maintain ethanol level, but we do not check ethanol level here that rapidly to monitor ethanol level. And as for fomepizole, we just have to give a loading dose and 12-hourly dose. And if dialysis needed, the patient have to be given 8-hourly fomepizole. By giving those medications, it blocks alcohol dehydrogenase, and the usual elimination half-life of the ethynyl glycol or methanol is about 3 to 9 hours. But giving those medications block alcohol dehydrogenase, and which extended its eliminated half-life, because everything have to go through the kidney. Elimination half-lives increase from 14 to 17 hours. Therefore, you have to monitor for longer duration. You have to keep under monitoring. And you can use hemodialysis in late presentations and very high poison loads. If indications are the acidosis like pH 7.3, respiratory failure, AKI, and very in visual abnormalities in methanol, if we do hemodialysis, the elimination half-life can be reduced to 2.5 to 3.5 hours, but it depends on the flow rate, obviously, but it reduces elimination half-life. Then moving to third case. A 67-year-old male with history of depression, fought with generalized tonic-clonic convulsions for more than 30 minutes. Patient never had fits before. When we assess, that was the situation, and we managed using these things. General measures were done, like get a line in, saline was started, oxygen was given, and we gave IV midazolam 5 milligram to control the seizure, and unfortunately, patient went into respiratory arrest, and we had to intubate and ventilate the patient. And we loaded the patient with phenytoin as well, because it has lasted more than 30 minutes. And on examination, patient had pinpoint pupils, and we were thinking of pontine hemorrhage, or we never had idea this was a poisoning when we got the patient, or stroke. That was the differentials, that initial moment. That's why we did the CT brain. It was negative. And then we started management as meningoencephalitis. The blood pressure was in the higher side. We started GT and infusion, and the blood gas and CBS was shown in the slide. And patient luckily recovered. And on day 3 of admission to ICU, patient was extubated. And when taken the history, patient has said that he took curator. And now only we knew that the patient has been a poison patient. Retrospectively, if we put RSI dead approach, we have done an initial resuscitation. Risk assessment, we didn't have anyone to take the history, and patient could not talk as well. Later, we got to know the patient had depression, and patient had been on fluoxetine, but it was not directed anywhere. And we started as treating as meningoencephalitis, and ultimately patient survived. And short duration of atropine infusion was given in the ICU, but it was discontinued because there were no clinical response. Regarding OP and carbamate poisoning, there are a couple of mnemonics that will be helpful to remember symptoms like the muscarinic symptoms, dumbbells like D for diaphoresis, defecation, U for urination, M for meiosis, B for bronchospasms, E emesis, L lacrimation, and S for salivation. Those things are predominating in OP poisoning, and nicotinic signs also can be there, sometimes in acute phase and mostly in the latter phase. Like you can go for days in the week, like Monday, Tuesday, Wednesday, Thursday, Friday, mydriasis, tachycardia, weakness, hypertension, and fasciculations. How we manage? Activated charcoal, questionable use. There are several places that it says that you can use activated charcoal, but there are many places it says it is not useful because OPs and carbamates are frequently formulated with hydrocarbon solvents. It has questionable use. Therefore, probably because it's a patient who's having a lot of vomiting and with reduced level of consciousness, probably you may complicate the picture by giving activated charcoal and things like that. Therefore, probably you can avoid it. If the patient is perfectly fine, you may use it. The important drug is atropine. The initial adult dose, you can use like 1.2 to 3 milligram IV and in pediatrics 0.05 milligram per kilogram. And you can double the dose every 3 to 5 minutes if there's no response and until the patient's respiratory secretions are clear and no bronchospasm and until the secretions are dried out. Because pupil response takes some time and heart rate may not be useful as endpoint because the nicotinic effect can result in tachycardia. And sometimes even in the beginning, the patient would be tachycardic, but the patient may be having all other features like bronchospasms, lot of secretions. Please do not avoid giving atropine just because the patient is tachycardic to like 100 or more than 100, like maybe just because of the nicotinic effect. Tiodoxime, it has a theoretical value, but it has not shows improving survival or reduce the rate of intubation. Therefore, I personally do not use tiodoxime. It's up to you guys to decide. Depends on your unit response. But there's no good evidence clinically to show that it improves survival in OP poisoning. Another important thing you have to remember is it has never shown significant secondary poisoning of staff. And you should not get worried that you will get poisoned because of management of organophosphate poison patient. Just use your usual universal precautions and manage in a ventilated room because that is to reduce the strong smell. And for seizures and agitation, you can use benzos. And carbamate poisoning, it's like similar toxicity, but it causes less life-threatening problems. Like, then moving into the fourth case. Rehabilitated drug addict, both with altered behavior and reduced responsiveness. The blood pressure was in lower side, she was bradypneic, and GCS was low, and patient had pinpoint pupils. Straight away, I thought like when we put it into a toxidrome, it's quite like opioid toxidrome. Which clicked my mind was like, oh, patient may have gone back and taken a lot of heroin or something. That's what I thought. And what we manage, how we manage was gave oxygen, gave naloxone, IM, and there was no response after 400 mics. Gave some crystalloid boluses. Because of no response, we were nowhere. And then we went for CT brain because we were not aware that the patient have taken a poison as well. And then after some time, we got wife, and she gave history that he took medications from a local hospital for addiction. and they were not aware, and then we had to contact that addiction clinic, and the patient has taken a polypharmacy overdose, paracetamol, rapidine, buscopan, olanzapine, diclofenac sodium, chlorpheniramine. He has taken everything which given for a 14-day period. And when we apply the protocol, oxygenation, we gave naloxone, no response. Crystalloid boluses were given. We have to later intubate. Risk assessment, these are the medications taken. And we have inserted indwelling catheter, and monitoring was done. Basic investigations were done. Initially, we did like CT, brain, and blood cultures, thinking of CNS pathology. And the time of ingestion was not clear. It seems to be like at least about 3 to 4 hours from the time of ingestion. And therefore, we didn't went for decontamination methods. And as antidotes, we use neck infusion because he has taken 28 tablets of paracetamol, and patient ended up in ICU. And the fifth case is straightforward. Young lady presented after deliberate ingestion of 24 tablets of paracetamol 45 minutes back. Patient was perfectly stable. We applied our protocol. Nothing really to do in the resuscitation. Risk assessment, taken 24 tablets, no medical issues, only vomited once. Symptomatic, like any basic parameters were monitored, and liver functions, ALT, AST was taken, and sugar was normal. And we gave activated charcoal because the patient was cooperative. No enhanced elimination. As antidote, IV neck infusion was started. Unfortunately, after the neck infusion, the initial part, patient dropped her blood pressure to 80, and patient developed generalized rash. We discontinued neck infusion, and methionine was not available. And we were like, I would check like whether there was facilities to check paracetamol level around that region. There were no facilities, and could arrange paracetamol level through relations from Colombo, from a private hospital, and the paracetamol level was done at 4 hours, because by that time it was around like 2.5 hours from the time of ingestion. At 4 hours, we did paracetamol level. We have up to 8 hours, and the paracetamol level came back below the nomogram level, and further antidotes was not required. When we think about paracetamol poisoning, there are like two concepts. One is single acute ingestion, large doses like more than 10 gram or more than 200 milligrams per milligram per kilogram, or repeated supratherapeutic doses. You have to consider paracetamol poisoning. And how we manage? In acute poisoning, if patient has taken more than 200 milligram per kilogram, if patient presented less than 4 hours post ingestion, you can wait until 4 hours and get the blood for paracetamol level. If paracetamol level is above the nomogram level, you can start neck infusion. If 4 to 8 hours, immediately take paracetamol level, plot in the nomogram. If above the range, start neck infusion. If more than 8 hours, if he is suggestive of taking large dose, take blood for paracetamol level and start neck infusion immediately. And once you get the paracetamol level result, you can decide whether to continue it or not. This is the ideal method. But what we do is, we just go with the history, which is a very unreliable method. And there are a lot of researches which has been done and which has shown that the patient's history is not reliable to decide on the paracetamol poisoning management. This is the nomogram we have to use. Decontamination, you can use activated charcoal or maybe gastric lavage. I'm not fond of gastric lavage anyway. Like, can consider activated charcoal for a cooperative patient until like around 1 hour, which will reduce 4-hour paracetamol level and which may avoid the need of neck infusion. But anyway, we are not doing paracetamol level. Anyway, we will be giving N-acetylcysteine, which is 100% effective treatment if it is given within 8 hours. Then what is the value of taking a risk of gastric lavage and giving activated charcoal if we are giving a very effective treatment, very effective antidote for all the paracetamol poisoning patients in Sri Lanka? Regarding neck infusion, please use the current hospital or unit practice, because now it is moving towards 2-stage infusion, like 200 milligram per kilogram over 4 hours and then 100 milligram per kilogram over next 16 hours, which has shown to significantly reduce adverse reactions with similar outcome. But for the time being, until it is being properly implemented, please use your unit protocol. N-acetylcysteine, which prevents napkin-induced hepatotoxicity. It has, like, they have discussed like about 4 mechanisms of actions. You will not remember those things. It is not necessary. And it causes anaphylactoid reactions. That is the problem. It can cause in about 10 to 50% of patients, especially after the first dose, because it's a very high concentration neck infusion we give within the first 15 to 20 minutes. Hypotension, rash, angioedema can happen. You can discontinue and use IV promethazine or H1 blockers like loratadine for management. If once the reaction settling, we can restart neck infusion. But why we take that much of risk? Probably it's time to introduce checking paracetamol level, at least in major hospitals, not to check paracetamol level as in developed countries which do not have any evidence, and costing analysis has never been done to check paracetamol level in all the poison patients, but to check paracetamol level in paracetamol poisoning patients and to decide on neck infusion. I think it will be cost effective. You will be able to avoid a lot of unnecessary neck infusions, unnecessary problems which be iatrogenically produced for patients by checking paracetamol level. Be in doubt, always in patients suspect overdose or poisoning in any patient with reduced level of consciousness or unexplained symptoms. Take home messages. Yes, it was quite lengthy lecture, because it was 1 hour. And first thing, don't ever do induced vomiting for poisoned. As a treatment or as a first aid method, never do it. Gastric lavage, very limited value, but make sure patient is conscious and alert and cooperative to do that. Activated charcoal, yes, you can use it in situations like, maybe in situations like digitalis poisoning, or like in situations where we have poisoning which we do not have proper antidote. It will be really helpful, but only during initial few hours. Resus RSI dead, that is the important thing. Supportive care is the mainstay of management in most patients. Keep in mind, treat the patient, not the specific poison. Do you have any questions?
Thank you very much, sir, for your excellent lecture. Yes, there are a few questions in the chat box. Is it okay if I ask them?
Yeah.
The first question they have asked, can suctioning be used in gastric lavage?
Suctioning is not advised to be used in gastric lavage. It is the recommended method is passive drainage, but I know in some situations you use suctioning, which can cause a bit of like damage to gastric mucosa, which can happen and can result in hemorrhages by suctioning. And if you ever do suctioning, make sure you do control sucking. Don't close that hole in the rigid sucker. But I think it's better to avoid suctioning in gastric lavage. I can see the questions. I can answer those things. Like how to decide on sodium bicarbonate in Tca poisoning. Yes, if patient is acidotic, if patient is having any ECG features like QRS widening, QT prolongation, in those situations, or if patient is having metabolic acidosis, or if patient is really drowsy and you are heading towards intubation, use sodium bicarbonate. You can give it up to the target I mentioned, like sodium level up to 155 and like pH up to 7.55, you can give sodium bicarbonate. Is Fomipizole available? Yes, it is available. Only thing is like many places it's not been requested in the annual drug estimate. As I said, it is just 25 rupees a vial. It is much cheaper than giving alcohol. Like you will never be able to produce alcohol for that cheap price. Is there a locally published handbook for poison management? Yes, there's like from the medical student days, we use our poison handbook, but it is there are certain places that we have to improve on. It is like but there are certain things that we can refer on, like because there are many local poisons like plants and all, like it is very important book, and we for further details you can like refer to websites like eMedicine or lifeinthefastlane.com is a very good site you can refer for managing. And how can we manage silica gel injection in a child? I'm exactly not sure. I may have to refer actually. Sorry about that. Intermediate syndrome, like in OP poisoning, it is being discussed and like, but the thing is there's no specific emergency management, mainly supportive care, which we do for intermediate syndrome. And like, therefore, like as an emergency point of view, I don't have much to add on for that. For anaphylaxis with NAC, what about adrenaline? Can't we use? No, we can use adrenaline. Of course, in our patient also, we used adrenaline because the blood pressure was low. But in the literature, it says like promethazine and the antihistamines, H1 blockers will be adequate because it's not really anaphylaxis. It's happening, what is happening is anaphylactoid reaction because of this the high concentration of N-acetylcysteine. If it's like do not settling, use adrenaline, IM adrenaline. There's no contraindication or anything. Case of Kaneru poisoning or Godakaduru injection present within 1 hour, can we induce vomiting? Don't induce vomiting. It can cause many problems and it is an unreliable method. For Kaneru poisoning, yes, because we do not have a proper antidote in our setting. We don't have Digibind here, which is a very expensive medication. And probably then you can use gastric lavage for even for like a little bit of extended durations. And then the other thing is like you can use activated charcoal. Make sure the patient is not drowsy, but do not induce vomiting. You do proper gastric lavage, which is a more reliable method than induced vomiting, because it can, I have managed many patients who have like gone through this induced vomiting and resulted in many complications because of the aspiration. I have intubated few patients as well, like one was a 14-year-old boy that was the only kid in the family, and luckily he survived. Yes, large particles cannot be removed from small NG tubes. I agree. That is why we are inserting a large bore NG tube, like it is number 36 or 40. Large tube we insert, and the lavage, we do repeated removal, like we put 200 mLs and keep some time, take it out, put it again and again, and like it will come out. So certain things will come out. Yes, that's why it said like it is an unreliable method. But vomiting also, it is not shown to remove all the particles in the stomach. Like you may see, like sometimes people vomit after taking some medications. After we give some medications, the tablets may not come out. That is the reality, and therefore we can't rely on that induced vomiting. It is not an excuse for induced vomiting. You can use gastric lavage, but it is also a limited practice. And I think that is all the questions. And thank you very much. I will end my presentation by saying that this is something that's said by like said to be the grandfather of modern toxicology. He said that all things are a poison and nothing is without a poison. It's a dose that make a thing not a poison. And this may be the last lecture for this year, 2022. Therefore, I would like to wish you all a happy new year 2022. Thank you very much.
I thank you again, sir, for your excellent and very informative lecture on emergency management in poisoning toxicology, do's and don'ts. I like to inform all the participants also the link for the e-certificate for participation has been sent to the chat box. So please find that and give your I will appreciate your feedbacks to improve future webinars also. This lecture will be available to you on Sri YouTube channel, and you can go through it again at any time to cover any missed parts to fix your knowledge. So thank you very much, sir, and also we also wish you a happy new year for 2022.